Good evening, dear professor and colleague. We will start the meeting of Aspella. We have a special guest, a very eminent figure in the field of oncology, Professor Mahsin. Professor Mahsin is a professor of medicine in Division of Hematology Oncology Department, deputy director and the leader of the GU Oncology program at Robert Hospital Comprehensive Cancer Center of Northwestern University, Finberger School. Professor Hussein has received many honors and awards, including the University of Michigan Award. She has been named for many years in America top doctor. Welcome, Professor Hussein, for our conference. We are honored to be with us. Dr. Maha will introduce a very important topic, which is update in the management of metastatic hormone-sensitive prostatic carcinoma. Welcome, Dr. Maha. The floor is yours.
Thank you, Professor Lubna. My pleasure. My presentation was already recorded, so it's been really a pleasure for me to join you, and I am hoping that next year maybe we will be face-to-face meeting. Okay. Well, thank you very much for the opportunity to participate in this meeting. Hopefully next time it will be in person. I am providing an overview of the management of metastatic hormone-sensitive prostate cancer. Here is a disclaimer. As you know very well, prostate cancer is a major cancer internationally, not just from an incidence perspective, but also from a death rate. Metastatic prostate cancer is the lethal phenotype, and it's in the United States, it's the second cause of cancer mortality. And amazingly, despite all the progress we have had, if you look at the estimates of death rates expected this year compared to 10 years ago, the numbers have not really significantly changed. Although the incidence has stabilized or decreased in most age groups, in the US, what we're beginning to notice that the incidence of metastatic disease has increased among men who are between age 50 and 69 years old, and the incidence of fatal prostate cancer has remained unchanged in men under the age of 55 years old. And I would actually be very interested in the discussion time to see what the numbers are like in Egypt. I'm going to begin with the historical perspective. As you very well know, the backbone of treatment in prostate cancer, ever since the original and seminal observation by Drs. Huggins and Hodges, is androgen deprivation therapy. Prostate cancer is an androgen-driven and dependent disease, and surgical or medical castration can induce significant regression. This work was published in 1941. As part of that work, in fact, they demonstrated the role of acid phosphatase as a potential biomarker for prostate cancer, one of the first biomarkers that reported in oncology in general. And in fact, Dr. Huggins received the Nobel Prize for this observation in 1966. What is interesting is this: despite a very high response rate, over 90% response rate, the majority of the patients will end up progressing to castration-resistant disease with a median survival of about 4 to 5 years. One of the major landmarks in the progress in managing this disease began when investment and research occurred, I want to say around the early 1990s onwards, to better understand mechanisms of progression to castration resistance. And the totality of the data would suggest that progression to castration resistance is a likely function of selection and adaptation via androgen receptor dependent and independent mechanisms. And that led to the identification for several pathways and targets and agents that have been evaluated in all kinds of phases from phase 1 to phase 3. Several of these agents, as I highlighted them in red, are currently approved for utilization for patients in the setting of castration-resistant disease. These agents not only approved in the US, many of them are approved internationally. As you know, one of the basic principles in oncology is identifying drugs that are active in advanced disease and then gradually moving them up into the earlier phases of the disease, which is the reason why I'm sharing all this data with you. As I will show you later on, several of these agents have been advanced into the setting of metastatic castration-sensitive prostate cancer. This is just a summary view of the landmark over the last basically 80 years, starting from the 1940s until today in terms of the pipeline of approval of different agents. As I mentioned, several of these agents highlighted in here have been moved up into the setting of castration-sensitive prostate cancer. Over the past 7 to 8 decades, there have been several treatment strategies that have been tested. As you very well know, bilateral orchiectomy was the first treatment approach. Obviously, this has several concerns, both from a physical and mental perspective for patients. And so medical castration became as an alternative and was evaluated. And then subsequently, several other management of the hormonal axis have been evaluated, including gonadal suppression versus peripheral blockade, the use of LHRH agonist versus antagonist. And beginning almost more than 20 years ago, or 30 years ago, therapy intensification concepts were evaluated with the addition of chemotherapy to hormonal therapy. Unfortunately, the older chemotherapy agents were not active. The concept of combined androgen deprivation, trying to target not just gonadal sources of androgens, but also peripheral, adrenal and other sources of androgens. Those actually is the only strategy historically that demonstrated some benefit. However, it did not significantly change the standards of care. And then the role of bone-targeted therapy, because of the nature of prostate cancer, where the vast majority of metastases occur in bone, were also evaluated in combination with androgen deprivation, but that did not impact outcome in the setting of castration-sensitive disease. The concept of intermittent therapy was also evaluated and was involved in a large trial. Unfortunately, it did not show a superiority or a benefit or even equivalence to continuous treatment. Now, as I will show you in a moment, therapy intensification is being revisited with the introduction of more active agents in addition to androgen deprivation as part of the management of patients with this stage of the disease. One of the critical points, not just in prostate cancer, but in cancer in general, we know that not all patients respond similarly. And certainly there are several prognostic factors that impact the outcome for the patients. And so in prostate cancer, one of the first prognostic factors that were identified in the late 80s in the original publication of Lupron plus minus flutamide. This is, again, the concept of combined androgen deprivation. In that particular trial, there was the first observation that, in fact, the location of the cancer seems to have prognostic effect. Patients tend to be better if they had axial or axial skeleton, as in spine or pelvis involvement, and or lymph nodes. And at that time, this was called minimal disease. And then extensive disease is any patient who had essentially appendicular skeleton, such as ribs or long bones or visceral organs. This was actually reconfirmed in a follow-up trial. This is SWOG 8894, which evaluated bilateral orchiectomy with or without flutamide. And as you see here, very clearly a significant difference in the survival between these two categories, further reaffirmed in more of the contemporary era in SWOG 9346 again. And one of the critical things is that others have looked at different criteria to characterize prognosis. The MD Anderson team looked at not just the location, but actually does the number matter. And as it turned out that the number seems to matter with regard to prognosis. And in that regard, the MD Anderson team had basically characterized high-risk patients at having at least 3 bone metastases or visceral disease, and again, demonstrating in their data a significant difference in the median survival. So all of this in totality was incorporated in the design of the CHARTED trial, which I am sure you're quite familiar with. This is a trial that was designed to evaluate the role of docetaxel or taxotere addition to chemotherapy. This was a US-based national clinical trial that took men with metastatic castration-sensitive prostate cancer and stratified them by disease extent. And for this particular trial, when it was designed and I was involved in the design of the trial, we incorporated both the SWOG definition and the MD Anderson definition, such that high volume was a minimum of 4 lesions with at least one in appendicular skeleton or visceral disease. And the low volume patients are those who have disease otherwise in there. And as you see here, overall, the study was quite positive with regard to overall survival. Interestingly, at the original report, which was presented at ASCO and published in New England Journal of Medicine, what was interesting to see was the fact that the patients who had high volume prostate cancer appeared to be the ones benefiting from the addition of chemotherapy, as you see here on the left-hand side, compared to those who have low volume disease. And interesting, 2 years ago, the overall survival data was updated. And as you see here again, the benefit that was observed in the high volume continues to be the case. And it's really quite significant compared to the patients who have low volume, where there does not appear to be a benefit in the addition of chemotherapy. There's been other trials that looked at the addition of chemotherapy. I would point out that those trials were not pre-stratified a priori for the disease extent. And there's certainly some concern that perhaps what the CHARTED trial observed may not be applicable, and maybe just an observation that happened. However, I feel fairly strongly that the way this trial was designed and powered clearly highlight the potential benefit. And in my practice, in fact, patients who have low volume disease, I do not offer them chemotherapy. It's only the high volume patients that I would offer them in the discussion and counseling regarding management options. Now, subsequent to that, additional trials evaluated, again, therapy intensification with the use of AR-targeted drug, again, the concept of combined androgen deprivation together with hormonal therapy with gonadal suppression as the backbone. And Latitude is, I'm sure, a trial you're very familiar with, again, reported 3 years ago, and again, demonstrated that the addition of abiraterone prednisone to gonadal suppression or androgen deprivation, in fact, resulted in significant overall survival difference. At the time of the original report, the data was available on 3-year survival. Subsequently, updated publication occurred, demonstrating, again, a significant increase in the median survival. And interesting, it isn't just the survival that was better, but also time to pain progression, skeletal-related events, delaying the time to starting chemo. Again, a reflection on the fact that these patients continued in remission for a longer period of time. Subsequent to this, data also was reported from Enzamet and Archies. The Enzamet trial was powered for overall survival. And as you see here, this is, again, demonstrating that the addition of enzalutamide to androgen deprivation improved overall survival and PSA progression-free survival, clinical progression-free survival. And Archies, again, was not powered for survival, but rather radiographic progression-free survival, again, demonstrating an improvement in that regard. And finally, palutamide was also evaluated and was reported last year, and again, consistent with what was seen in the prior trials, demonstrated an overall survival benefit. One point I would like to highlight is that in the subgroup analysis of both the Enzamet and the apalutamide trial, what was interesting to see is that in the forest plot, that the patients who have seen prior docetaxel, so let's say a patient gets diagnosed today with with metastatic prostate cancer, they get hormonal treatment and get started on chemo, and they were allowed to be entered into these trials. Interestingly, if they've seen chemo, as you see here, it does not appear that the benefit is the same as those who have not seen the chemotherapy. So I do think that piling up drugs is probably not a good idea at this moment. And I do think that patients should be counseled based on their disease extent and so on with regard to the use of chemo versus AR-targeted drug in the setting of high volume disease. And then in the setting of low volume disease, certainly any of these AR-targeted drugs would be what I would consider in addition to androgen deprivation. So one of the biggest questions that I get asked by patients and certainly by colleagues is, now that we have all these choices, how do we go about choosing what would be an appropriate treatment for these patients? And on the left-hand side, I created a table that summarizes all of the trials that have demonstrated, again, an overall survival or clinically meaningful benefit for patients with the use of these drugs on top of androgen deprivation. And one of the things that I think is important is we know that all of these agents have an overall survival advantage. That, as I mentioned, docetaxel appears to be benefit-wise, specifically in high volume patients. And the question is how best to choose. And I do think that from counseling the patients, there are certainly several trade-offs in the discussion. There's issues of toxicity, therapy duration, physical cost, financial cost, obviously patient preference. And one of the options that I get asked, or the questions I get asked about fairly frequently by patients and by colleagues, is androgen deprivation treatment alone still an option? Well, I think potentially it is, but I do think that if the objective is to prolong life and reduce side effects related to the cancer, certainly therapy intensification is what I would recommend. Now, there are times, and again, I would be interested to hear the average patient ages that you see. And, as patients now are living longer, prostate cancer becoming more and more an issue there. I do see patients in their 90s, and the question comes up is, should they get any of these agents? And this is really where the conversation becomes important with the patient regarding the pros and cons of management. One of the important things, again, in managing the patients, but also in preparing for or better understanding of how the treatment is working, is the issue of how do you assess benefit and how prognostic is the observation in this regard. And one of the earlier observations that we have made based on the SWOG 9346, which evaluated intermittent versus continuous androgen deprivation, was the fact that the nadir PSA can be very strong predictive factor. As you know, in prostate cancer, a lot of the patients have mostly bone disease, and bone is very hard to evaluate with regard to response, because you do a bone scan, the lesions don't necessarily go away. So is the patient responding or not? And so we evaluated different cutoffs for PSA declines, including a PSA in the undetectable range, which is less than 0.2 nanograms per ml. And what was very interesting to see that a PSA decline of less than 0.2 nanograms per ml led to the best possible overall survival outcome compared to patients who went down below 4 but still above the undetectable range. And for the patients who actually did not achieve PSA decline or had a rising PSA, actually had the worst outcome. This was confirmed in the charted data, as you see here. Again, the different cutoffs, and this is irrespective of which arm the patient was received, and is broken down by chemotherapy and hormone treatment or hormone treatment alone. Again, the point here is response is associated with better outcomes. And this is data from Latitude, again, reaffirming the observation that patients who achieve significant declines and definitely nadirs of PSA in the undetectable range do the best overall. This actually allows counseling the patient, deciding on timing of imaging and different things in terms of a management thing. And certainly it's been an important endpoint in evaluation of certain treatments, because as you know, with this disease, patients could live many years, and certainly response may not be possible by measures because not all patients have measurable disease. These criteria has been incorporated in clinical trials that are screening different agents in this disease. There are several ongoing questions that I would like to highlight. One of them is the story of the oligometastases. Oligo actually in the dictionary definition-wise would imply 1 to 3 or 1 to 5 lesions. And metastases-directed therapy has been a strategy that has been evaluated for many, many years. And the objective in it is to avoid androgen deprivation or systemic therapy. So if a patient has 2 or 3 lesions, or 1 lesion for that matter, could this be treated with radiation treatment, for example, and then spare the patient the need for hormone treatment because of all of the physical and mental side effects of these treatments? And one of the first report was actually a literature review that was published several years ago, looking at metastases-directed therapy of regional and distant recurrent disease in the treatment of the disease. And this was as I mentioned, a systematic review. There was several single-arm cases or series, and total for 450 patients. And the conclusion was that metastases-directed therapy is a promising approach for oligometastatic disease. The level of evidence generated by these small case series was really low level of strength or evidence such that one would not change their standard of care. Now, there are few few small clinical trials that are ongoing. One of them is Oriole, which was reported recently. And this included 54 patients that were randomized to observation versus stereotactic radioablative treatment. In this regard, again, this is a small clinical trial. They looked at 6 months progression, and the 6 months progression was much lower in those who received the targeted radiation treatment. The median progression-free survival was not reached in the group of patients who received the focal radiation compared to 5 and 8 months in those who did not. I do think that, again, this is interesting data, but of course, a small series and not enough follow-up. And critical to all of this, obviously, is the impact on overall survival and the potential benefit there. Now, there are several issues to be addressed in this, and I would say in this setting, in my practice, I do not do androgen deprivation treatment. What I do actually is androgen deprivation therapy and chemo or AR-targeted treatment therapy intensification, but certainly we are exploring with patients the focal radiation concept on top of this as a potential benefit, because there's, again, the emerging data with regard to the potential benefit. There are several issues to be addressed, I think. How many lesions and where, and the sensitivity and accuracy of imaging. Obviously, now that we're getting much more sensitive imaging with PSMA and the different PET imaging, that's going to be picking up disease earlier, and potentially there may be the advantage there. The other part of it is if somebody has only 2 lesions, but this happened to be liver, is that a good idea or not? And so there are some of these questions that need to be answered. The question also that I think is important in the design of the trials, what is the objective of treatment? Is delaying androgen deprivation treatment clinically significant enough versus impacting overall survival and meaningful progression-free survival? And I think this could be a philosophical discussion, but I do think it's important to also address. And then, of course, what we need is prospective phase 3 clinical trials, which, as I will show you shortly, are ongoing. Now, one of the other questions that also needs to be definitively addressed is the potential role of targeting the primary. So as you know, many patients can present with de novo metastatic prostate cancer. That is to say, their prostate is still in place, it has not been treated. At diagnosis, they have metastatic disease. And the question comes up is, should targeting the prostate also be a part of the management in addition to systemic therapy? So one of the trials that have reported on this question is the STAMPEDE. And as you know, STAMPEDE is a multi-arm trial that's asking multiple questions. In this setting, it evaluated the role of radiation to the prostate in the context of patients presenting with metastatic disease, so they're castration-sensitive disease. And the patients were pre-stratified a priori by disease extent of or the volume of disease that they have. And what was interesting is this: in the overall population, as you see here, you don't really see much of a benefit. However, when you look at the subgroups of patients who have the low burden versus high burden, there is a very clear distinction and separation of the curves with regard to failure-free survival and overall survival. Now, one could argue that these subgroups have not been powered for. However, as you'll see here, this cohort had over 800 patients. And to me, when I look at this particular data, I feel that this is strong enough data, pending, again, prospective trial data, strong enough data that I would actually offer patients the potential for local treatment if, in fact, their prostate is still in place. And this is a list that we published last year in JCO as part of a review of all of the current clinical trials that are ongoing in the context of patients with metastatic castration-sensitive prostate cancer, several of them addressing therapy intensification, as you see here, including actually the incorporation of radiation treatment to the prostate in the context of de novo disease, and radioablative therapy to sites of metastases, and then definitive treatment again to the prostate, including the potential for radical prostatectomy in some of these clinical trials. And I'd like to make one comment, because I do think this is something that's going to emerge on the radar screen very soon, is the issue of personalizing therapy with the use of precision medicine. As you know, genomics have really made major headways in a variety of solid tumors, breast cancer as example, ovarian cancer, lung cancer, and now we're beginning to see the impact of genomics in prostate cancer with the recent approvals, at least in the US, and consideration in Europe, two targeted drugs, PARP inhibitors, olaparib and rucaparib. And one of the questions that I think is important in prostate cancer is to understand where best to begin to think about precision medicine in these patient population. And this is data, again, it's cohort data, highlighting the fact that the patients who have metastatic castration-resistant disease, which is on the right side of the slide, appear to have, as you might expect, significant mutational burdens amongst different genes. And clearly, I think it's too early right now to consider definitive targeted therapy in the concept of patients with local disease, although there are some clinical trials ongoing. Clearly, in the patients with the metastatic castration-sensitive disease is perhaps the window, because you do see significant mutations compared to the patients who have local regional disease, but it's not as complex and as significant in terms of the burden as those with castration-resistant disease, with the hope that actually one can have a better impact there. So I want to highlight with a summary at the end of my discussion is that several progresses have been made in the management of this disease. One of them is that overall survival is clearly improving over the decades. And I just use this as an example. On the left-hand side, these are the 3 SWOG trials that evaluated different strategies of hormonal therapy. And as you'll see, beginning with the original trial that was reported with the addition of flutamide to Lupron, where the median survival was barely 2 years, looking back now into the more of the late 1990s and 2000 era with the 1993-46 trial, which evaluated the intermittent versus continuous therapy. When you look at the control arm, patients right now live much more longer than they actually lived previously. The other part, which is an observation we have in the US and with Egypt being in Africa, I wonder if there are racial effects that are observed with regard to the biology of this disease. But in the US, historically, men who are Black, or as they're referred to in here, African American heritage, appear to be worse. And as you see over the decades, actually, their outcomes have, in fact, appears to be improved. And when you look at the, again, the more recent data, there's a pretty much comparable outcomes with regard to median survival. The other point is that prostate cancer is a chronic disease. While the majority of patients don't live 5 years, a significant percentage, even in the era where we didn't have the better overall treatments, based on the trial that, again, the intermittent trial, we looked at the control arm and looked at the 10-year survival estimates. Somewhat about 17% of patients have lived 10 years. And this is, again, despite the fact that we did not have that many life-prolonging treatments at that time. So my anticipation right now is that men who are diagnosed now are likely to even live, the rate will be much higher, 10-year rate would be much higher than what we have observed before. And this is just updated data from Charted to highlight that even the patients with high volume disease have a 7-year survival rate of about 33%. And interestingly, again, this is of course with the chemo arm, and then again, those with low volume disease, half of those patients will actually live 7 years. So again, highlighting the fact that prostate cancer is a chronic disease, and with that comes in the issues of clearly the side effects and importance of managing the patients, because as patients get older, they get other comorbidities, and so all of these things have to be balanced. So I want to end with the charge moving forward, which obviously is going to be focused on significance and impact and value. Clearly, therapy intensification in the context of metastatic castration-sensitive or hormone-sensitive prostate cancer is now the standard of care. The combination of docetaxel with androgen deprivation, particularly in the context of high-volume patients, the addition of abiraterone with androgen deprivation, enzalutamide with androgen deprivation, or apalutamide, all of these agents improve overall survival in patients with metastatic castration-sensitive disease. Prostate cancer biology and heterogeneity clearly, and its ability, it's a very sneaky cancer, and its ability to adapt really highlights the fact and the need that we need to do therapy intensification sooner rather than later, with the aim at a cytotoxic impact. And I do think that, as I showed you, we can convert this disease into a chronic disease. There are several issues to be considered. Clearly, with the better imaging, we're going to likely to see patients who we now call them non-metastatic castration sensitive. They're going to get converted into metastatic castration sensitive disease because we're going to pick up metastatic disease much earlier. And I do think this will provide a window of opportunity for better outcomes. Clearly, the role of molecularly targeted therapy in pre-selected patients is an area that is of interest, and I guarantee you we're going to begin to see this. It's already began with some phase 2 clinical trials, but definitely it's an area that's going to be expanded on. And one of the questions that I wonder about myself is therapy de-intensification. I'm sure you may have patients who've been on treatment for 5 years and they are in remission. Is there the option to consider stopping these treatments? And I think potentially, I do think it's going to be important to do trials to evaluate that. And one of the questions is this: when can we stop treatment? Is 3 years enough? Is 5 years enough? So I do think this is a question that's going to be important. And as you know, as patients live longer, clearly survivorship becomes important. All of the treatments we give potentially have side effects, and certainly long-term side effects become important. So survivorship, wellness, and addressing cost and value for the patient is very important. And with that, I would like to thank you very much for this opportunity and extend my gratitude from Chicago. Thank you very much.
Thank you, Professor Maha, for your elegant, comprehensive presentation. Now the floor is open for the question. Let us start with the first with me, please. For fit patient, young, 47 years old, with no comorbidity, presented with high volume tumor burden with visceral tumor. Okay, your recommendation, please, in era of COVID, Do you recommend tablet therapy plus ATT or to start with chemotherapy?
That's an excellent question. I think that there is the option for both. Obviously, the COVID situation has created a big problem in terms of the concern over myelosuppression and such. Having said that, I have not really stopped offering the chemotherapy. Clearly, you'd have to be careful about the patient and protection and so on. I worry about purely AR targeting in this setting, considering the visceral disease and the fact that there could be a good component of this cancer that may not be AR driven. And so consequently, I would say, assuming you think you can do it safely, I would probably err on the side of chemotherapy with androgen deprivation.
Okay. Now in Egypt, gallium PSMA is available, affordable. Do you recommend in biological labs with doubling time more than 15 months to proceed for gallium or conventional radiology?
So this is relapse after local therapy?
Yeah.
And did they have surgery or radiation?
He treated with radiation.
Okay.
And then after 16 months, doubling time for PSA, do you recommend to proceed for gallium or just conventional radiology?
Well, in terms of imaging or therapy?
Yes, imaging.
Imaging. You know, that's a very good question because obviously in the US, we haven't had like standard of care gallium imaging at this moment as part of the routine care. I definitely would use the level of the PSA and then decide as to what would be the best tool. If a patient has a very low PSA, I would proceed with the gallium imaging first, and then go from there. I have had situations with the I guess the oxymin PET would be the similar imaging, where in fact an abnormality that was picked up by that PET or by PSMA either resolved on its own, which is weird, or seemed not consistent with prostate cancer. And when I biopsied the disease, turned out to be something else. And so I would say go ahead with the imaging, but be mindful that those types of imaging may not actually give you 100% the clinical situation.
Thank you so much, Professor Maha, for being late. The schedule, we have a lot of questions. We will share it with you. Thank you so much. It's our honor to be with you.
Thank you. It's my pleasure, and this is a fantastic meeting. Thank you.